Hello, happy Tuesday. I'm Michael McNutt, Director of Education and Events at WEDI, and on behalf of the association, our President and CEO, Charles Steller, our Board of Directors and Education Committee, welcome to WEDI's Virtual Spotlight, Provider Directories Solving for the No Surprises Act, sponsored by InterSystems. Before we begin, allow us to share a little information about WEDI. Recognized and trusted as a formal advisor to the Secretary of Health and Human Services, WEDI is the leading authority on the use of health IT to efficiently improve health information exchange, enhance care quality, and reduce costs. Created in 1991 by HHS President Dr. Lewis Sullivan and named in the historic 1996 HIPAA legislation as an advisor to the Secretary, WEDI has been instrumental in aligning the industry in an effort to harmonize administrative and clinical data. With a focus on advancing standards for electronic administrative transactions and promoting data privacy and security, WEDI drives strong unified public-private partnerships to improve health information exchange by bringing together organizations from across the healthcare spectrum, including providers, payers, vendors, and government. With a focus on advancing, one slide, there we go. By convening healthcare leaders and driving consensus-based solutions, WEDI has been successful in resolving current data exchange-related roadblocks and continuously motivates the industry toward administrative automation. WEDI educational events bring together the brightest minds in the industry to give talks that are idea-focused, foster learning, and provoke conversations that matter. If you are currently a WEDI member, thank you for your membership and welcome. If you are not, we encourage to connect with us to see how you can be a part of positive, effective change in the industry. WEDI workgroups and sub-workgroups provide thoughtful leadership and common sense approaches that enhance the exchange of clinical and administrative healthcare information. These volunteer-based groups provide the lifeblood of the association as they collect input, exchange ideas, and make recommendations that inspire impactful and far-reaching change in our industry. After today's event, if you would like to continue the dialogue about provider information and directories, we encourage you to participate in WEDI's Provider Information Workgroup. Its co-chair, Michelle Berry from Availity, is the moderator for today's event. We will also be holding a workgroup open house on May 11th, open to the public. Visit wedi.org to sign up. To take us through today's agenda, housekeeping, and special acknowledgement of our sponsor, InterSystems, I'd like to hand it off to my colleague, Bill Alder, Associate Director of Business Development Membership. If you're not a WEDI member, Bill is the man with the plan for you.
Thank you very much, Michael. Appreciate that kind introduction. To Michael's point, my name is Bill Alder. I am the Associate Director of Membership and Business Development here at WEDI. To our WEDI members that are in the audience today, thank you very much for joining us. To our non-members in the audience, feel free to reach out anytime. If Michael's coverage of the organization has piqued your interest, we'd love to talk to you more. As you can see from the slide in front of you, we have a great agenda for today. We'll begin with an overview of the current state of provider directories from a stakeholder panel representing multiple different perspectives. Shortly thereafter, we'll go into some legislative mandates and describe the technical approach to the No Surprises Act, where you'll be hearing from my colleague, Robert Tennant. We'll then hear from Alexandra Muggy from CMS with a few updates. And lastly, we'll circle back to our multi-stakeholder panel where they will discuss how best to implement the requirements of the No Surprises Act and also open up the floor for some audience Q&A. Next slide, please. For those of you already familiar with Zoom, you would move your mouse cursor back and forth, and on the taskbar that appears, you will see that chat button that is circled in red on your screen. Please feel free to punch your questions in at any time, whether those questions be for our presenters today or just to engage with one another here in the audience. Important to note is that the slides that you may see and also the recording will be shared with all of our registered attendees after the event. So please know that those will be coming your way shortly thereafter. Next slide, please. Of course, I want to say a big thank you to our sponsor for today, InterSystems. InterSystems has been providing innovative data solutions in the healthcare sector for many, many years. And we would encourage you to check out those solutions. Included at the bottom of the slide here is actually a URL that links you to some use cases that are relevant to the industry was intended today. I'll punch that URL into the chat as well, in case it makes it easier to download those. But thank you very much to InterSystems. And next slide, please.
Oh, that's the next slide. It's our honor to welcome Michelle Berry from Availity, who is our co-chair for our provider information work group, who will start the discussion.
Good afternoon. Hope everyone is having a wonderful week, and wanted to share we have a great opportunity with some of the best experts around provider information in our healthcare marketplace today. So again, we're going to open up. If we can, we've got several panelists. I have a couple of questions. There's no hidden questions. So this is a panel discussion. We're going to hear from each one of our panelists. The first question that I do have, and think about it from a member perspective. I know most of us are consumers of healthcare today, and we do understand the space around provider information, finding the right provider, going into your health plan's directory and searching for a particular provider that's in network to service your medical needs. So what are you hearing from your membership? Amy, if we could start with you.
Sure. So I guess I can answer this from a couple of different perspectives. So from the physician practice community, the pieces that we're hearing really are more about the collection of the information as opposed to the searching in the directory. I will say that in a survey, it's a couple of years probably, but we did have physicians that expressed concern that they were seeing about 52% of them said that they encountered a patient virtual every month that was having coverage issues due to inaccurate information in a provider directory. So they relied on something that they saw in a provider directory that ended up causing coverage issues. So from our perspective and our membership, which is really going to be physicians and the practices they serve in, this continues to be an issue that people are navigating. And I think it's interesting time now too, because it's further compounded with, I think, what's going on environmentally too. So, there's lots of questions now about what additional information do patients need to be able to really be able to choose the physician or provider that is right for them. So as they're looking at, are these additional components that should be included in a provider directory? If we're talking about building on the top of directories and we haven't gotten some of the basics right yet on, location and phone and whether or not you're in my network, that can be concerning. So, I guess I would stop there and just with the kind of a broad overview there.
Fantastic. And Josh, I know you're with the American Heart Association, but what are you hearing from your membership as well? And Tammy, great perspective from an AMA perspective, our physicians, our practitioners. And again, this is a great dialogue. So Josh, I'm going to turn it over to you. And what are your thoughts and what are you hearing?
Sure. So from like a consumer patient point of view, provider directories certainly have the potential to be more valuable tools for patients than ever before, providing patients with the ability to accurately locate a provider that is, both convenient to where they live or work, and also help determine whether that specific provider is in their health plan's network. I think, however, and to date, many patients have had to deal with inaccurate provider directories. And as Tammy mentioned, in 2018, the AMA released the results of a survey of 700 physicians, in which 52% respondents said their patients encounter coverage issues due to inaccurate information in provider directories. Another recent study by Health Affairs that looked at privately insured patients who received specialty mental health treatment found that 44% had used a mental health provider directory, and that 53% of these patients had encountered directory inaccuracies. All this while, I think mental health is in limelight right now, given the pandemic. But all this to say, inaccurate directories and patient use of inaccurate information directories can result in frustration, delays in care, the inability to locate a participating provider, with available appointments. And in the past, mistaken use of out-of-network provider because of inaccurate directories have resulted in surprise medical bills and increased out-of-pocket costs for patients. So while network status is one of the crucial bits of information important to patients, so is spoken language, provider location, hours, skills, and experience. And when inaccurate, the results can be, anywhere from a minor frustration to delays in care.
Thank you. Those are really good points as well. And again, when we talk about membership, we're talking about the AMA's membership with their physicians and, from the American Heart Association, those individuals that are looking for the right practitioner. And you bring up some really good points. The numbers are just incredible between what you and Tammy have shared with the team here. Those numbers are extremely concerning. And I know from our provider information work group, that is some of the things that we're hearing from even our own providers that participate in our work group. So let me turn it over to Linda. And Linda, what are you hearing from your members?
Yeah, so, both our customers and prospects and the payer and provider side are grappling with this in, a number of different ways. From the provider perspective, if you think about the rapid acquisition practices by large IDNs, creates a huge set of fragmented data. They also have not just the EHR, they have their, PeopleSofts or whatever their human resources system, they have the credentialing systems, or they get their credentialing. There are so many sources that have provider information that sometimes just keeping up with that volume of information is daunting. And then they've got all these relationships with all the payers that they have contracts with that they then have to provide that information to. And so if you think about that aspect of it, that's a sort of, gee, how often and how much information do we have to share? On the payer side, it's the same problem, right? They've got, again, they're getting data in from all the provider network, but they have their own internal sources of information, largely fragmented across many, many siloed systems internally, not necessarily one source of truth. And so I think that's the sort of holy grail, is how do we find and create that sort of source of truth in a way that doesn't overburden in terms of the amount of work and labor that has to go into. So it has to be commensurate. So that's the problem, right? It's like you can't just create this huge sort of workforce issue while you're trying to clean up the information. And I just want to dovetail as a patient. One of my favorite things is to be a secret shopper and to see how sort of good or bad information is. So I pretended I was looking for a new primary care physician. I figure, every once in a while in my life, I'd have to do that. And so I went to the large IDN's, website, and I searched and said, let me find a new provider. And I had criteria like we all do and said, has to be near to me. But, for me, a couple important things is, do they accept my insurance? And, oh, by the way, are they accepting new patients? I then looked at that site, and the one thing it didn't say is, whether or not it didn't have information about whether it was in network for me, big problem. And it also didn't say whether the new provider was accepting patients. So then I went over to the health plan side, did the same search. Well, so the good news is that after doing that search and finding the provider, they accepted my insurance, but guess what? According to the website, they weren't accepting new patients. So that's like a sort of a exercise in frustration that I think we've all gone through as patients. So that's sort of part of the problem, is that it's not just fragmented on one side, it's fragmented both ways.
Right. Agreed. Great scenario, especially as a shopper. I think we all get into that, frame of mind and you literally try to see if the provider is even at that service location based on the telephone number that's present, to even see if they're accepting new patients. So it's interesting, and I think, this is great information, because we do need to look at all of the pieces of the puzzle and try to bring together synergies. So, Soren, let us know what your thoughts are around what you're hearing, you and team are hearing around provider directories.
Sure. Well, obviously at CAQH, we hear a lot from our member organizations and the payer community in general, as well as the provider community, but with a heavy focus on the payer community. And directories and directory problems have been at the top of the list of issues and concerns right now that health plans have been trying to address. So far, the panelists have touched on all of the key issues that are driving it. From a health plan perspective, a directory is one of the most public-facing things that the plan puts out there and provides to its members and to the market as a whole. The patients are dependent on a directory, and most importantly, its accuracy to access care. I think it's already been referenced several times, and the notion of secret shopper. I think many of you know CMS, for 3 years, there was a gap of 1 year because of COVID, conducted secret shopper audits on provider directories. It was for MA, but was, I think, representative of the industry as a whole. And it was shocking, first pass, 50% error rate roughly in directories. Now, if you think about how large an industry healthcare is, what are we, 18% of GDP as a whole? That's a significant chunk. Yet what industry could possibly tolerate 50% error rates in one of its most important public-facing documents? So clearly it was a wake-up call. I don't know how much of a surprise, but definitely a wake-up call and a focus. Lots of money has been spent, lots of ideas are out there, and I'm sure we'll be discussing more of that on one of the following sessions today. But what was interesting is, despite all of that effort, the second time the audits were conducted a year later, guess what? It was also roughly 50%. It's like we barely moved the needle. And it wasn't for lack of attention, because certainly risks of penalties and what have you sharpen the focus to try to solve the problem. Yet we didn't succeed. And I regret to say that the third audit that was done, which was, I guess, 3 years later, roughly the same result again. So it seemed like the industry was not succeeding in addressing the problem. Now, we've done some analysis in terms of when you look at the error rates, that 50%, roughly 60% of that 50% error rate was provider not practicing at that location, not seeing patients at that location. And when you start to dig into that, okay, how's that possible? How do you get published in a consumer directory when you're not really seeing patients at that location? And some of the things we're finding and have seen is that we have so many data inputs and so many sources for information, which can often be conflicting, that it creates part of the problem. A big example, many payers rely on their claim systems to get data about provider practice locations. But when you look at what providers are doing, they're wanting to be associated with any possible location that they may bill from, but not necessarily treat or see patients or want patients to make appointments at those locations. But that information doesn't come through. So the net effect is payers will publish what the providers are affiliating to, even though it's for claims purposes. And now suddenly they're being identified in a directory as practicing at a location. When a patient calls, they're often told, no, you can't make an appointment with this provider here. This provider doesn't practice at this location. So those are some of the examples of what we have to overcome.
Right, I agree. And I think the rest of this audience definitely can relate to every panelist here, whether the individual is a practitioner, even representing a facility or an ancillary provider or even an atypical provider. So again, I do understand and appreciate the discussion, because having this open discussion leads us into our next question about solutions. And what are you hearing in regards to solutions? And Josh, if I could start with you, what are you hearing as far as solutions are concerned to addressing inaccuracy or inaccurate information in the provider directories?
Sure. And I know we're going to get into specifics a little later in the agenda around like No Surprises Act and requirements. But, you know, overall, our view is that the new accuracy requirements and accompanying cost protections will provide patients with timely and accurate information to help them avoid accidentally using out-of-network services for non-emergent care. You know, just our view is that more accurate directories will allow patients and consumers to make, you know, more informed choices about where they receive their care, and, you know, actually have peace of mind that the information they're relying on is accurate. You know, I think we can all agree that patients with chronic conditions already have enough to worry about between managing their condition, work and family commitments, and that the last thing they should have to worry about is whether or not a provider they found in their plans directory is still in network, speaks their preferred language, and is available during the hours listed. You know, I think whatever the solution is, and we're pretty solution agnostic, we support what's in the No Surprises Act. But I think our ultimate
I think I
view
pulled
is
it up
that,
and Chris has pushed something to test for this. Thought I just looked at that.
I think someone needs to mute. But anyway, where I was going with that is I think provider directories ultimately should be a resource for patients, and not like an added headache as they navigate their care.
Right, right. And that's a great comment and suggestion. I do hear we might have some folks that are also mute. If you could, please go on mute. We would greatly appreciate it. So with that comment, you know, you're right. No surprises. We're going to be talking about more of that and related to HR 133, specifically around provider directories. And what is that? What is the meat and what is the requirement? So Rob and Alex are going to go through
in the
that
cafeteria,
exercise.
you know, and that's an example of something that we think would not be useful.
Sorry about that, all taken care of.
Thank you. So hopefully everybody can hear me. And just want to say, I know we're all excited to have the discussion, the open discussion today at 2:45, but we still need to get through some of our really good questions. And Josh kicked us off with our second question around the solutions. What is he and team specifically hearing around some of those solution items? I know we talk about solutioning in different ways. And Linda, from a technology perspective, and what are you and team hearing as far as solutioning is concerned?
Yeah, so sort of agnostically, right? What people want is more automation in helping them clean their information, right? Because investing, like I said, a lot of human resources in it is just not the best way. And so trying to find ways to sort of clean up that data and help with the automation process. I think the other thing we're just hearing is that managing provider information is a program, not a sort of one-stop shop. In other words, if I'm a payer and I say, this is a project and I'm just going to work on this project for the next 4 months and I'm going to clean up the information, and then that's the end of the project because I've sort of, you know, achieved my goal. It's not like that. You know, with 25% of provider rosters changing annually, and we talked about that, you know, moving the provider changes locations. That's sort of, it's got to become more instantiated as something programmatic that happens on a regular basis. And again, like I said, it's a combination of sort of, you know, people effort and technology effort to do it. I think also the whole collaboration between payers and providers, and the more that becomes a partnership as opposed to, you know, I'm going to throw it over the wall and let somebody else worry about my, you know, the bad data. You know, I saw one of the questions was sort of, you know, well, what do you do? You know, why is this the payer problem? Well, for whatever reason, this is sort of how the regulatory framework has been established. But quite honestly, it's a partnership, and we always want to talk about how can payers and providers work together to solve it. And sometimes it's through technology, sometimes it's an intermediary broker that helps do that. So I think there are a lot of different ways, and I think we'll get more into that later. But from our perspective, it's commitment and assistance from sort of technology to do it.
Absolutely. And partnerships are critical more now than ever. And I think you bring up a very good point is, connecting everyone together, and technology seems to bridge those opportunities and strengthen relationships. So again, that was, you brought up some really good points there, and want to turn it over to Soren so that he can share what he's hearing from a solutioning perspective.
Thank you. Yes, thank you, Michelle. And it's very interesting, Linda. We would totally agree with you. I certainly would totally agree with you that technology is a critical component of this, but technology is a tool. At the end of the day, there is a need to understand what are your sources of information, how is that information made available, how is it updated with now what is great frequency, because with no surprises, we're looking at 90-day confirmations of data. And then how is, and this is where payers are spending a lot of time now, once you have received data, and they are getting data from multiple sources, a whole bunch of silos, including the provider community. We at CAQH focus a lot on that interaction from the provider. But once you've got all of this data coming in, you have to, one, review it, work with it, and critically important, how do you reconcile differences in the data? There are no really acknowledged sources of truth. It's been a holy grail. Even CMS has stated in its 2018 report, I think, that, quote, it has become clear that a centralized repository for provider data is a key component missing from the accurate provider directory equation. And that's an interesting statement from CMS, because there's still folks in the industry that on that subject, centralized source of truth versus federated, everybody share your data and we'll figure out how to clean it up and come to the right answer, is still going on. I don't think that there is the right answer. We've worked closely, and Tammy can speak to this, with the AMA this past year on the very point you raised, Linda, which is, let's start with aligning the parties that are sort of the data suppliers, the providers and their practice managers, their practices, and the data consumers, which are the payers that have to take this data in, clean it up, and then publish it for their membership and hope that it's right. And clearly there is a need for that partnership to get even stronger than it currently is. And that can sometimes be difficult. Payers and providers haven't always been best of partners, but I think that's changed radically. And on administrative simplification, especially these arenas, the value of those type of relationships are huge. So the payers are very interested in making these things work. And Tammy, I'm sure you can comment from the provider side on how that, perception is received by the provider community.
Yes, and Soren, thank you. I think this is a great segue for Tammy. I think what we're talking about is really bridging the gap with opportunities. And it always starts with making sure that we've got our health plans, our payers, and our providers understanding what is required, what level of information should be, kept and updated and attested and verified. And that is one of the things that we're hearing from our health plans as well. So Tammy, from an AMA perspective, what have you heard as far as physicians coming to you or practitioners coming to you for any solutioning opportunities around provider directories?
Yeah, and I think a lot of the, a lot of the other panelists have covered some of this, but I think, the area of focus has been getting back to basics, I'm going to call it, and getting on the same page, finding that common ground. I think a huge first step, Soren mentioned the work we've been doing with CAQH in the form of just education to acknowledge that both sides have a role to play in service of patients. And I do believe that both sides do acknowledge that. And then it becomes then, okay, how do we move forward? And so, where we have landed is really, like I said, getting back to some basics, moving away from like the common complaint from the payer side is the practices won't give me the information, and the common complaint from the practice side is I give them the information and they won't update it, they won't use it. So how do we get from that scenario to, we're working together in the service of patients? And, we've come up with a couple of key things, I think, and places to start, which is to start looking for identifying some root issues. So what are the causes for some of this? Soren brought up an example of one of them where, a physician who maybe provides coverage at a location on every once in a while, that the practice shouldn't list them in the directory. They should, and you shouldn't report that they practiced at that location because it is in a blue moon in a coverage situation. Yet there's a concern over if they do provide care there, how is that impacted? How is reimbursement impacted? So I think there was a pilot on a national level where the payer gave the practice the opportunity to distinguish between those things, differentiate, and it improves the quality of the data being able to do that. And I think this is something that came out in a CMS audit too. I think just building that transparency between health plans and practices. So when you see information that is wrong, reporting it, know where to report it, so that folks aren't frustrated trying to get through to the correct person. Practice are still being inundated. They are just being barraged with update here, update this here, do this one via email, go to this portal. Here's this one's going to be in fax. One wants 6 pieces of information, one wants 12. It's overwhelming. It's just one other thing that gets in the way and interferes with patient care, which is kind of what we're all here for. So I think to the extent that we can get to common standards, common data definitions, just some basic information that's required, and everyone agreeing on those standards and what those fields are, would be a huge step forward in the right direction, to be able to get rid of all this customization, and really remove burden really on both sides. Michelle, you mentioned awareness. I think that practices are grappling with so much administrative burden right now. So it is a matter of creating awareness and the importance here. And then just coming back to that key point of collaboration again, how do both sides start working together to move this forward in the service of patients?
Fantastic. This has been a great discussion around, what we're hearing and what we're hearing around solutioning and where are the pain points. And Tammy, thank you for, just bridging everything that we've talked about so far. So I'm going to recap a couple of items. One, I just want to make sure that I share our thanks and appreciation for this panel. Soren, Tammy, Linda, Josh, we have got the best representation in our industry right here, folks. And they have offered up their time to really explain what they know and what they understand. And it's not about just numbers. You can hear the compassion, the desire to bring the healthcare industry together to solve what we've been talking about for a couple of years. And technology, Linda and I know, and Soren and Tammy and Josh understand technology and how that bridges some of the gaps, but education, outreach, partnerships, all of that play a role in what we've heard today. So I want to say thank you all. We appreciate the participants joining too, because without you being a part of this opportunity, we wouldn't know how important it is to you. And we see by the overwhelming participation today that we do have additional opportunities to go to that next level. So be on the lookout, more information coming soon. If you're interested in joining our WEDI Provider Information Work Group, we meet every second Wednesday of the month from 3 to 4 p.m. Eastern. We would love to have you participate. If you have any questions, Bill and Michael will be more than glad to help out. Sam, I think you're on the webinar as well, the Zoom meeting. Any questions that you have, we can answer. We can get you additional information. We would love for you to participate. We have a great charter scope, and we work really hard to bring people together to solve for provider directory inconsistencies or aberrancies. Around no surprises, we're going to be talking about that in more detail here in a few minutes. But again, just wanted to say thank you to the WEDI staff as well for bringing us together today. This is a great opportunity for us to continue the same level of cadence. And again, no surprises, HR 133 around provider directories is just one of many places where provider information is critical. I can't say it enough. You've got to have the right provider information for an auth, for a certification or notification, especially from a CMS perspective, for certain observation inpatient stays. So there's a lot of information that's contained within provider information. It helps with the claims, claim status, eligibility and benefit checks. So there's a lot that provider information plays a huge role in every type of communication, transaction. And again, keeping that level of information current and stellar and accurate is really important. And, some folks will say, well, it's not just about provider directories anymore. And I shake my head and I smile. It is more than just provider directories, but our focus today is really driving into that no surprises. And around a couple of things before I turn it over to Rob and to Alex to go into the details. But WEDI really continues to address legislative mandates. In our work group, we focus on that. We look at the mandates, we look at the law, and we determine, we pick it apart, we decide, what is applicable around how we can educate and inform the healthcare industry around provider information. So no surprises is no surprise to provider data, provider information. It's going to continue to move forward with changes and modifications, but today we're going to really drive in that discussion about provider directories and no surprises and who's on point for what. So I would like to turn it over to Rob Tennant. And Rob, if you would like to take the floor, you and Alex, we would appreciate it.
Thank you, Michelle. And let me add my thanks to the panel of experts for the really stimulating discussion of this issue. I think what I heard was two commonalities. The first being we have a problem, and the second is we want to come up with a solution. So I didn't hear anybody say we're happy with the status quo. And we're all in the healthcare business, but we're all patients as well. And I think what I heard loud and clear from Josh and others is that this is a patient care issue. That yes, it's the responsibility of health plans and providers, but at the end of the day, this impacts patient care. And I think that is the message that Congress got when it started to look at the issue of surprise billing. So as you all know, and we can go to the next slide, as Michelle said, it was folded into HR 133, and I have a link here. So if you're bored while lying on the beach this summer, you can certainly read the entire bill. But Congress sought to address a real concern in the industry, and that was patients getting hit with surprise bills. And I think there was a strong bipartisan support for that aspect. But at the same time, Congress took the opportunity to address other key data exchange issues in the industry. And one of them was, of course, included in Section 116 of the bill, protecting patients and improving the accuracy of provider directory information. So if we go to the next slide, what I want to do is just sort of walk through some of the requirements for both health plans and providers that was included in the law. And I wanted to recognize CMS. They've put out some wonderful resources on this issue and other aspects of the law. And I was able to draw on some of those resources for my slide deck. But one thing to remember, this law is in effect. It went into effect January 1. And when I first talk about this, I'll focus on the health plans because it's important to know that for the covered health plans, group health plans and health insurance issuers, any that offer a group or individual health insurance coverage, so it's a pretty broad group of health plans, they are required to not less frequently than every 90 days, they must verify and update their directory information included on their database. So that's a very hard date. Every 90 days is quite a lift for the health plans. And of course, they have to establish a procedure for removing a provider or facility who is now not in network. And update their database within 2 business days of receiving information from a provider or facility. That is a very fast turnaround time. But again, I think Congress is stepping in and saying, we have to do something about inaccurate directory information. Next slide. So again, a lot of the this section of the law is focused on patients, and so they're saying here that if an individual, if a patient requests information from the plan through either a telephone call or by going on the website, they have to have information regarding whether or not the provider or facility is in network. And very importantly, in response to the inquiry from the patient, the plan has to get back, of course, if it was through a telephone call, within 1 business day of receiving the call. So that's, again, they can't delay for a week or more. It's got to be very quick to get back to the patient with the information that they are asking for, and that the plan is required to retain that information in the individual's file for at least 2 years following that phone call. Next slide. And the other big issue here, we've talked about, making sure we know if the provider is in network, what the provider's address is and phone number, but also with the No Surprises Act, we have issues around balance billing. So that the health plans must make available on their website and include on every explanation of benefits of course, the law says in plain language, they have to put in the requirements and prohibitions on balance billing. Not for every circumstance, and of course, I could spend all day discussing the specifics, but just know that for most of the situations, you're going to have to put in the requirements and prohibitions on balance billing. As well, if any applicable state law or any other requirements regarding what a provider or facility can charge, that has to be on the website as well. And information on contacting appropriate state and federal agencies in case the individual feels that the balance billing requirement has been violated. And that, for those that follow HIPAA, you'll note that that's very similar to what the requirement is for the privacy notice, that there has to be an inclusion of some government entity that they can contact in case they believe there's been a violation of law. Next slide, please. On the provider side, first of all, it's important that virtually all providers are covered. It doesn't exempt any specific categories of providers or facilities. So it appears, at least in terms of the statute, as if all providers are covered under the law. But I have a note here, and you'll see this note throughout the rest of the slides. There is expected rulemaking from HHS, from CMS at some point, and Alex may give us a little glimpse into when to expect some of those regulations. Next slide. So what does the provider have to do in order to support more accuracy in the directory information? Well, they have to notify the plan or issuer whenever the provider or facility begins a network agreement, whenever they terminate a network agreement, or if there's been any material changes to the content of the provider directory information. So for example, if the practice changes locations, if they add a location, if they change the phone number, all of this information must be sent to the plan or issuer, and any other information that is requested by either the plan or ultimately if HHS decides that additional information must be exchanged between the provider and the health plan. Next slide. So in terms of other requirements, the provider again must remove from the directory if a provider has terminated their contract. And again, it's very common, and perhaps even more acutely so because of the pandemic. There's been a great turnover in clinical staff at practices. So it's not a small task to ensure that the information is up to date that is given to the plan. And importantly, there is some financial responsibility, as we'll see, for if they provide inaccurate network status to an enrollee. And again, as I said before, we expect to see additional rulemaking in this area at some point. Next slide. So again, back to the patient focus. Again, starting this year, providers and facilities must refund enrollees any amount paid in excess of in-network cost-sharing amounts with interest if that enrollee has inadvertently received out-of-network care due to an inaccurate provider directory information. And again, that puts a lot of pressure on the provider to make sure that that information is accurate and that the patient has access to that accurate information. And then they have sort of a catch-all phrase that the provider must maintain processes to submit provider directory information at specified times to support plans and issuers. So again, there's no specificity in terms of what that process has to look like, but there has to be a process in place. And again, with all of these types of laws, in many cases, the enforcement angle is left up to the agency, in this case, probably CMS. And so a part of the rulemaking may include, and again, we may hear more from Alex on this, but it may include some enforcement in regards to all of the requirements for both plans and providers. Next slide. So in terms of the information that must be shared with the health plans, of course, names, addresses, specialty, telephone numbers, and digital contact information for the individual providers. And then the same information must be provided for the entities itself, whether it be a medical group, a clinic, or a facility, and whether or not, again, they're in network. And of course, the note again is we'll probably see more information come out from CMS on this in terms of the specificity. And again, I wouldn't be surprised if we saw some timelines around this as well. So next slide. So again, there are cost sharing limits associated with any incorrect directory information. Again, if the individual relies on the information they got from the provider directory and that's incorrect or inaccurate, and they receive out of network charges, then the plan has to limit cost sharing to the in-network terms. And they also have to apply the deductible or out-of-pocket maximums as if the provider or facility were in network. So again, they're trying to take the onus off of the patient and give patients more rights in these areas. And you can see that this falls within sort of the broad umbrella of no surprises, that they shouldn't be surprised with excess fees due to inaccurate directory information. And of course, the provider or facility must not bill the individual more than their in-network cost sharing. And I note as well that, again, much of this will be included in future rulemaking. And so again, I don't know when we'll see those rules, but we will see them at some point. And next slide. I think that's, we got one more, I think. So if the individual relies on the incorrect directory information, if the provider submits a bill to the individual that is more than the in-network cost sharing, and if the individual actually pays that bill, then again, the provider must reimburse the individual for the full amount paid by the individual that is in excess of the in-network cost sharing amount plus interest. And again, we'll hear more about this in rulemaking, but you can see again that the provider is on the hook here, and it's going to be a lot of administrative burden if the directory information is incorrect and the patient relies on that. So again, they're putting more onus, more pressure on the providers to make sure that that information sent to the plan is accurate. And next slide. So again, if the patient or the individual does get these excess bills, again, we are expecting a rulemaking, but the law says that if the rulemaking does not come out, the providers will have to work with health plans and make a good faith effort. And this is also a big part of the No Surprises Act in other areas, but they must make a good faith effort to adhere to the requirements of the law. So they can't just say, well, I'm waiting for the rulemaking to come out. No, they've got to make a good faith effort. And because a lot of states currently have regulations on the books regarding some of these issues, including the accuracy of provider directories, the law states specifically nothing in this section of the law shall be construed to preempt any provision of state law relating to healthcare provider directories. So they're saying if a state law is more stringent, that will take precedent over this particular law. And again, I've said that a lot of the specifics around implementation of the No Surprises Act will be determined through rulemaking. I think that's it. And with that, I'm happy to turn it back to Michelle to introduce Alex.
Great. Thank you. Appreciate it, Rob. That was a lot of great information, specifically around provider directories, no surprises, HR 133. And I wanted to give us a few minutes here to open up the discussion with our partners at CMS. Alex, I think you are on the call with us this afternoon.
Hi, yes, I am.
Great. Thank you and welcome. I'm turning the discussion over to you right now.
Thank you, Michelle. And I am actually going to share my screen because I did, well, I have at least one screenshot that's going to help answer some of the questions in the chat. So if I could, if I can share my screen, it'd be great. All right, we are going to go to this slide. Can y'all see the giant CMS logo?
Yes.
We sure can.
All right, great. Okay, so I don't have a lot of slides to show, but this will at least allow you to look at something other than my name box lit up in the Zoom. So I want to thank Rob too. He made some great statements about the No Surprises Act. CMS is actually, because we are in that rulemaking process that Rob mentioned, we are actually not going to be talking about the No Surprises Act today. And unfortunately, because of the nature of rulemaking, I can't speak to what could be happening with the rule. But I wanted to talk to you about some other things that are happening within the provider directory space, and actually start with a little bit of a history on provider directory. And actually, I'll come on camera too. Hi. All right. So first, I wanted to just start off because I know that there's a lot of attention being paid to the No Surprises Act, and I wanted to highlight that this isn't the first time that Congress has taken action in the provider directory space. I'm going to run through some of the history here, so just bear with me because there's a lot. But provider directories have really long been a focus of the federal healthcare improvement efforts. And on several occasions, Congress has taken action to address the challenges of healthcare directory information and data accuracy. So this is certainly not the first time, though this is definitely a significant impact. Again, it's not the first time that they've done this. So again, there's no test here at the end, but I am going to run through some of this history and just bear with me because I promise I'm getting to a point. So we're going to start with the Balanced Budget Act of 1997, and that was 25 years ago. For those of you like me who need a reminder that 1997 was 25 years ago, seems like it was just yesterday. But anyway, the Balanced Budget Act of 1997 actually established the Medicare Advantage program, and it modified the Social Security Act to require that Medicare Advantage organizations would annually disclose in a clear and accurate and standardized form to each of their enrollees the number, mix, and distribution of plan providers and some other information. So keeping in mind, this is back in 1997, and Congress was talking about clear, accurate, and standardized information about provider directories. The Balanced Budget Act also modified the Social Security Act to require that Medicaid managed care entities make available upon request the identity, location, qualifications, and availability of providers that participate with that entity. So very important that we're talking about network availability, especially for folks in the Medicaid program. Then we're going to jump ahead to 2015. So big lapse in time there. But in 2015, through rulemaking, CMS established a requirement that qualified health plans issuers on the federally facilitated exchanges must publish an online, easily accessible, up-to-date, and again, accurate and complete provider directory. So again, there's that word accurate, where Congress and CMS are both focused on the accuracy of these healthcare directories. CMS also required that these issuers make the information publicly available on their websites in a machine-readable file. So using our authorities, CMS has reviewed and strengthened some of this guidance for directories over the years. For example, in 2016, CMS issued a call letter announcing that it was initiating a monitoring effort regarding the accuracy of online provider directories for MA organizations. We followed this up by starting a study to examine the accuracy of those MA organizations' online directories, and there's more information about that study available on our website. In 2016, Congress enacted the 21st Century Cures Act, which was a significant move in the electronic space of provider directories. As part of the Cures Act, the Secretary of Health and Human Services is required, either directly or through partnership with private entities, to establish a provider digital contact information index, or also referred to as a directory, to provide digital contact information for health professionals and health facilities. So this is the first time that we're starting to see or have discussion about digital contact information in the directory space. And I know there was a question in the chat about how we're interpreting that digital contact information. So I just wanted to highlight that on my team's website, on cms.gov, we do have an FAQ that addresses some of this, and I'll give you the link in just a moment, but I'll leave this on the screen for those of you who want to just take a quick look. And I'll share the link to that information in just a moment. But in any case, so the Cures Act was really the first time that we were talking about digital contact information and making that available in the directory space. So we've gone from accurate and standardized form that we talked about in the Balanced Budget Act of '97 to an online machine readable format, which we talked about with the qualified health plans and our rulemaking. And now we're talking about digital contact information being available through these directories as well. So in support of the Cures Act, in 2018, CMS updated the National Plan of Provider Enumeration System, or NPES, to be able to capture that digital contact information for both healthcare professionals as well as facilities. And to drive engagement and use of that feature in NPES, in May of 2022, CMS published the CMS Interoperability and Patient Access Final Rule, in which we finalized our policy that we would publicly report the names and NPIs of those providers who do not have digital contact information included in NPES. Unfortunately, when we published that report in December of 2021, that report included a list of approximately 2.9 million providers and clinicians that did not have digital contact information yet listed in NPES. So we clearly still have a long way to go. But circling back to the Cures Act, the Cures Act also requires Medicaid state agencies to publish an online directory of certain physicians who participate in the state's program. These directories must be updated at least annually and must include providers' names, specialties, address, and phone numbers. For certain physicians, the directory also must include whether they are accepting Medicaid beneficiaries as new patients. And this can be a critical function of a provider directory, is determining whether the provider is accepting new patients with a particular type of insurance. Particularly for our Medicaid population, this was critically important and a significant step that the Cures Act took to improve directories for folks in that population. Then in 2016, the Office of the National Coordinator, or ONC, also hosted a provider directory workshop to convene public and private stakeholders to discuss the provider directory issues and challenges that our panel also previously discussed on the call today. The workshop discussed concerns about data quality, administrative burden, and also customer satisfaction. To address some of the concerns, ONC and their industry partners began work to develop an HL7 FHIR implementation guide to define the underlying architecture for a national directory of validated healthcare data. I know that some of the panelists talked about a source of truth or a federated state of healthcare directory, and ONC's development of this architecture certainly helps to support some of the underlying architecture that would be necessary for such a directory build. ONC and the industry partners have also continued this work through the FHIR at Scale Task Force, or the FAST Task Force. And last fall, CMS officially began supporting FAST through in-kind resources and contributions to ensure that this critically important work can continue. In January 2020, as a follow-up to the Medicare Advantage Provider Directory Monitoring Study from 2016, the one I mentioned that was announced through the call letter, CMS issued a memo encouraging Medicare Advantage organizations to work with their contracted providers and urge them to review and update their NPES data. So we're starting to see us all working together at this point, and work towards that single source of truth by having private payers encourage their providers to update a national system. And this is work, I should say, that is ongoing. I think there are still there's still a lot of work to be done in this space, but it is an example of CMS working with private industry to try to improve data accuracy in our own systems. And as part of this, we did in turn say that CMS would exercise an enforcement discretion should we uncover any errors in the MA organization's provider directories, provided they correct those errors within 30 days. So again, I heard a lot of panelists saying that we needed to work together to solve these problems, these challenges, and I think that this was a step in the right direction there. Then finally, the last piece of history that I'm going to share here is that in May 2020, CMS finalized the CMS Interoperability and Patient Access Final Rule, which required that by that we finalized that by January 1st, 2021, Medicaid, for all the payers that were regulated by this particular provision, the MA organizations, Medicaid and CHIP fee-for-service programs, Medicaid and CHIP managed care plans would all make their standardized information about their provider networks available in a provider directory API. This API would be conformant with the technical standards that were finalized by ONC. So again, we've gone from a form that is an accurate and standardized form to online and machine readable directories to now, at this point in time, the policy has gone live that the provider or the payers covered in this rule are now required to have an API of their standardized data available for public use. The provider directory APIs are required to be accessible and public facing through a digital endpoint on the payer's website to ensure that they can be used by the public, by developers that are out there, and by patients as well through the developers' applications. So all of this history that I just went through, like I said, there's no test, but hopefully you stuck with me through some of that. All that's to say is that we're working on it. These requirements are evolving, and I think they're getting us closer to where we need to be. We know that the federal government has taken steps, and we are well aware that private industry has also made efforts to improve provider directory data. We also understand that the challenges still exist. That's why we're here having this conversation today. And you heard a lot about that from the panel earlier and some of the challenges that are there and some possible solutions to address them. But maintaining accurate directory information is hard, partly because it requires collaboration between providers, payers, and even federal government entities or state government entities for that matter. But when you think about it, I mean, I'm just thinking about the time that I changed my address a few years ago. When you change your information, you have to update that address or phone number in many places, probably places you don't even remember that you have that information, with the post office, electrical services, any subscriptions that you have. You have to update that information in a lot of places, and it's easy to miss one. Now imagine if you're a provider and you have to update that information in all of those places, plus 16 payers that you contract with, as well as CMS. What if you miss one? Or what if you miss all of them? Or what if you're too busy taking care of patients to consider all the places that you need to update your information? This is a reality, and it does happen for providers. And it's also hard on payers too. So much of our regulatory and legislative policy looks to the payer to keep this information up to date. But the burden of keeping this information up to date is real. And it's just as hard for payers as it is for providers and everyone else. Unfortunately, the reality of it is that directories play a critical role in healthcare. And consumers use provider directories and online searches more than any other resources to locate healthcare services. So for better or worse, we have to solve this problem of data accuracy for our consumers. And those consumers are, of course, patients, just like you and I are. We're all patients. We're all going to need to locate a provider at some point or another. So having accurate data and data that we can rely on is critically important. So I guess where to go from here. I will say that as I discussed through the history, our legislative and mandates and the policies around healthcare directories has continued to evolve over the years, and so have the needs and use cases of our directories. And I think that we'll continue to see that happening. A modern healthcare directory must assist patients in locating providers that meet their individual needs. I think we can all agree on that. but it could also support healthcare providers, payers, and other entities to identify another's digital contact information for interoperable data exchange. That's a second use case that we haven't looked at for healthcare directories in the past. There's the consumer support aspect and making sure that the data is accurate. There's also, of course, payment considerations and all those other historical reasons why we need directories, but there's also this interoperable aspect of it. Getting that digital endpoint available is critical for interoperable data exchange. In addition to that, as we come out of our joint experiences with the COVID pandemic, we also have to evaluate the role of directories in connecting public health entities to support better public health data exchange, because that's also a use case that can be a reality for healthcare directories if we can get that data to be accurate and timely and available. So a little bit about my team. I guess I'll go back a slide or two. Not that you need the slide, but I'll just put it up here on the screen anyway. My team is the Health Informatics and Interoperability Group at CMS, and our mission is to promote the secure exchange, access, and use of electronic health information to support better informed decision-making and a more efficient healthcare system. So it should be no surprise that I believe the appropriate use of technology can make a significant difference in the accuracy and availability of healthcare directories. Accurate and timely healthcare directory data is critical to our team's mission and to the future of healthcare data exchange. And what's different now, what we didn't have when we started this discussion of directory information roughly back in '97, is that we now have technology available to support improved accuracy of directories. Soren on the panel earlier mentioned that technology is a tool, but we need to evaluate the source of data. But what if that tool, that technology that we have available could go back to the source to say you have a problem? What if that technology was able to analyze the data that we have available, identify where the problems are, and go back to that source to get that corrected? What would this really mean? So let's take, for example, the APIs that I mentioned that we finalized in the CMS and Interoperability and Patient Access Final Rule. Sorry, speaking too fast and don't want to call it a proposed rule or something. It is indeed finalized. These APIs that we finalized in the rule help to ensure that health plan directory data is available in a standardized format and is available through an API. So what if industry developers could use those APIs to compare directories in an automated way, identify inconsistencies in the data, and then use existing technologies to provide feedback where inaccuracies might exist? Or what if providers could update their information one time through an API, and that update would filter to all of the payers that they contract with, instead of having to update their data with each payer individually? There is technology available today that can support this, but we have to work together to get there. The technology can also support better data exchange when the digital endpoints are available, and that can support better patient care. So unfortunately, I don't have a magic solution and no special announcements today. Again, I know Rob mentioned that there will be future rulemaking, and that is true, there will be. So more to come on that. But unfortunately, due to the nature of rulemaking, we can't talk any more about that today, but hopefully more to come soon. What I will say here in closing is that I think we do have the tools and resources we need to improve data accuracy. I believe technology and the right support from industry and policy will help us to achieve some of these goals. But I will also acknowledge that we have a long way to get there. But believe it or not, I think that we're on the right track. So with that, I'm going to just, like I promised, share the link for more information. If you have questions about our policies from the Interoperability and Patient Access Rule, those are available on our website. There's also an inbox that you can email with specific questions if you don't see that in our FAQs or otherwise listed on the website. And my information is also listed here. And with that, I think I'm turning it back to Michelle to open up for maybe some Q&A. Thank you.
Thank you, Alex. Thank you. We appreciate the information. Sounds like we've got some work to do together as an industry. So again, just want to say thank you. Appreciate it, Alex. And I misspoke earlier. I said that we were going to open up the lines. We're actually going to be doing chat. So if you have a question that you would like for the panelists to respond to, highly recommend you type it in the chat feature. Again, if you're on Zoom, please make sure you go into the chat feature to enter your question. We're going to be monitoring those particular questions coming through the chat feature. And again, bringing back our panelists, talking to Soren and Tammy and Linda and Josh around the things that we're trying to do in the industry around no surprises, and what are some of those best practices that we could potentially implement based on no surprises provider directory call out, HR 133. So I'm going to go ahead and open it up to Josh. What are your thoughts around best practices and how we can implement the requirements of no surprises?
All right, so kind of a couple things here, and it may be a bit of a different perspective, just given the patients we represent. So of course we are eagerly awaiting the future rulemaking with a keen eye to how the process will work for patients especially when they receive inadvertent out-of-network care due to an inaccurate directly. I think in general, and this really applies to all parts of the No Surprises Act. We encourage the departments, HHS, CMS, Treasury to undertake a broad, well-funded education campaign and notify consumers of their rights under the NSA. Not just the more well-known patient protections that we've been more focused on, but also around, information on various transparency provisions, including requiring more accurate provider directories. I get the sense from talking with advocates and patient volunteers that right now Google and word of mouth are still the primary tools used for finding a provider. I think if there was some sort of, did you know PSA around parts of the NSA, including around directories being more frequently updated, consumers may turn to them more confidently. I also think plans can play a big role here, simply by communicating this information with their enrollees about, kind of new and improved and accurate directories.
Great, thank you. Great points there. Education, outreach, making technology a part of that search opportunity for consumers, beneficiaries, subscribers, dependents. So I think that is definitely one of the best practices, but you use Google as an example, and you're right. A lot of people look at that rating of that particular provider based on feedback and insight from individuals who potentially have utilized that particular provider. So that is a great example. Soren, what are your thoughts? What are best practices in implementing these requirements around no surprises?
Yeah, and from a payer perspective, and I was really, I learned a lot from Alex today, which was really great. Thank you. From what we're seeing, we think from a health plan now, some of the responsibilities and things that they could be doing to support and comply with no surprises, but also to start to fix this, putting aside, the legislative drive to do it. It's like, we need to fix it. So one is streamline data channels, the update channels that payers are using. There's so many of them. They're often in conflict, and reconciling them is a problem. So can we weed through that to have fewer sources that are more accurate and credible? Follow, and it's been said a few times already, follow best practices and standards on data collection and required data fields, so that the industry starts to say the same thing means the same for everybody and we're all doing the same thing. Provide practices with a way to differentiate between locations where a clinician regularly sees patients versus where they may occasionally support but don't really take appointments with patients. Update their directories quickly. Now it's going to be required, although we will need clarity because a 2-day turnaround is pretty severe. And when you have multiple data channels, if they're in conflict, how do you update in 2 days without reconciling between differences you may see? But we definitely need to update directories quickly. And as important, if not more so, provide transparency to practices when updates cannot be made. Explain what's going on and why. Proactively inform and resolve data conflict issues with the practice. It's very much reactive instead of a proactive approach. To the plan, internal systems need to be harmonized and bigger investments in automation for high quality updates. And lastly, but not least, is also simplified plan participation information. The business model has often made it so complicated that it is difficult for the patients and for the providers, and candidly for the plans, to know what are you participating in? How do I correctly connect the dots between the product and what the provider thinks they are supposed to be part of and what the patient is expecting? So to me, those 6 items are some of the big things that if we can address from certainly a health plan perspective, we'll make a lot of progress.
Fantastic. That's great insight and feedback. You know, you talk about standardizing terms, and for instance, we notice in No Surprises, it just says name of the provider. And, you know, the conversations around, is it doing business as name, or is it legal name, or is it Michelle using her middle name because people recognize me by Michelle versus Kara? So, you know, I think to your point, that's spot on, because we do need to make sure that people understand what is name, you know, and making sure the provider is able to be found by the individual consumer, beneficiary, subscriber that's looking for that particular provider. Because if I know provider A as Michelle Berry and not Kara Berry, the likelihood of me selecting Kara Berry is probably slim to none. So, you know, and again, we're hearing a lot of that really good feedback. So I think you're again, bring up a very good topic of standardizing the terminology so that people do understand what we mean by name. And so that it's not different from one directory versus another. So that brings me to, you know, Tammy, what are your thoughts around the best practice or, you know, best in class when it comes to implementing requirements around No Surprises?
Yep. So I'm going to echo a few things, and actually, you know, no surprises aside, you know, this is just sort of general information for just improving directories as a whole. And I'll give Soren a big shout out for the streamlined data channels. That would be amazing. But I think even I mentioned going back to basics earlier, we're talking about really nuanced data. So, you know, this data ages at a rate of 24 to 36% a year. So if you do nothing with your data, you know, you're going to have 24 to 36% of it that is inaccurate by the end of the year. So I think, and it's nuanced in the fact that I may be a provider who practices at 5 locations. You know, 2 of them, I accept patients in this network, and the other 3, I accept patients in another network. One of those contracts might leave that all to me, so that if once I reach a certain patient capacity, it's up to me whether or not I'm accepting new patients in that network. And another contract might say that, no, I'm always going to accept patients in that network. So you're talking about really, really nuanced data that we're trying to, you know, streamline, and getting it right is really important. So I think going back to the who's responsible for what. So we've had a lot of conversation, and I see a lot in the chat too about practice locations. You know, so knowing if a provider is practicing at a location, what the phone number is, if you've moved your location, all of those things really fall to the practice. They're the front line on that. And then when you move to the network piece, that, you know, the payer is like the official keeper of that with the contracting information. You'll find that a lot of physicians in particular will know that they accept Blue Cross Blue Shield, but they won't know exactly which plan within Blue Cross Blue Shield they're accepting. So again, just a lot of nuances with this. So that's where I keep saying, you know, going back to the basics here, with standardization, expectations, so that if we, you know, make clear that, hey, the practice, your first line for that location and that phone number, health plans, your first line for the network. And then the other piece that was mentioned earlier that I think sometimes gets overlooked is this whole notion of data silos. And it happens on both sides. So from the practice perspective, you might have one database for credentialing, so verifying all of those credentials for an individual. And interesting, you brought up name. We had a whole conversation about that the other day. Should it default to license name or legal name, or what should be used? You also they might have a database for enrollment. They might have a database for marketing, how they project their practice and what it looks like to the community. And then they might have another one for directory. Some of this information is common between the two of it, some it's very nuanced. So being able to streamline that and be able to pull out and supply the correct information for the correct use case becomes very important too. So no single bullet, no magic bullet that gets at this in its entirety.
Fantastic. Well, we are right at 5 minutes to the hour, and I know there's a lot of questions coming through the chat feature, and I'm trying really hard to keep up with them. I just want to say thank you, everyone, for participating today. We do have a lot of work to do together. This is something we collectively can do. I think it's just a matter of joining forces and determining how we can bridge some of these gaps, use best practices that we've utilized and know that work, and understand, things are changing. We're going to see change as we continue moving forward with technology, as well as just federal and regulatory requirements. And it's a good change. It happens for reasons, and we all know together we're better together. So I would like to turn it back over to Michael or Bill to conclude today's session. I know we've got so many questions coming through the chat feature. I'm hopeful we can get responses back to individuals as soon as we can. Also, we've got a few more minutes left. So if there are other, Rob, if you have any additional information, Alex, if you would like, you can have some more time answering some of these questions that we are getting through the chat. Quite a bit around the technology piece, and Linda as well. Linda, what are your thoughts around moving technology at a pace that I know I hear, and I say this wholeheartedly because I know sometimes technology is very difficult for folks, especially for small organizations, our small provider groups, or one doc practices, or a facility that may have 500 leased network providers. What are you hearing around best practices and anything that we could do from a technology perspective that would help lead? And it's not a one-size-fits-all, right?
No, it isn't at all. And, Alex made some great points that through the regulatory process that, CMS and ONC is starting to sort of make this easier, but it's baby steps. And I think people may not appreciate that when CMS puts into, a final rule, share your provider directory information through FHIR API endpoints. That kicks off a whole process for a vendor. It also kicks off a process for, the provider or payer. And that process is 18 months or more. And I don't think, sometimes we appreciate that really is a true timeline. And so if you think about on the EHR side, APIs to enable US CDI is going to be required of technology vendors under CERT starting the end of this year, but that's just US CDI. That's not the entire data set we're talking about here, right? So if further rulemaking then says, okay, well, let's expand that to include things that would need to be included in a provider directory. Well, now, at least as she was saying, we'll have API endpoints, right? Where sort of share once, use many, so that from a provider perspective. But if you think sort of some of the larger EHR vendors are sort of on top of this. When you think about the diversity of small EHR vendors that are serving our small provider practices nationally, that curve is way longer than the 18 months I was talking about. And so I just think that this is going to take time, right? So there's sort of curating the data within your own organization. And then there's the, how can we make it easier to share that information once I've put the energy into doing the curation? Because, you know, I think Soren said, you know, you've got faxes and portals and all kinds of ways of getting the data back and forth, which is not high tech at all. It's not using interoperability. It's not using that enablement we want to see. But that will take time. But I think, you know, Alex's sort of path she brought us along through the history shows us that we're making progress. And I think that within the last 5 years, we have made significant progress in this direction.
Well, that's a really good clarification and understanding. I do think that ultimately people do feel that one size fits all, at least, you know, what I'm hearing from some of our smaller health plans versus smaller to large, medium provider groups. And, you know, we've got a wide range of individuals participating in the WEDI Provider Information Work Group. And it's great to see that interaction and to hear, you know, feedback or, you know, technology concerns. And, you know, Alex did a really good job of explaining the accuracy of the data is where that focus is. But you also have to get the data, the accurate data, to the right entity. And Linda, you said it, and so did Tammy, and so did Soren, and Josh too. There's so many different places, and Alex did a great job of explaining, you know, as a consumer, if you're changing your address, you have to go to the DMV, you have to fill out different applications for transferring your electric, your car insurance, you know, your health insurance, everything that, and then what happens if you forget one of those? You know, the consequences are back on you as the individual that had that change. And, you know, again, we hear constantly from all of our membership at WEDI around, you know, provider information. It's not just for directories. Having that accurate provider data shared amongst entities and organizations. But Linda, you said it, Soren said it, Tammy did as well, you know, having these multiple locations for our providers, doesn't matter if it's small, medium, or large provider group, if they're having to maintain their data, even through fax, scan, email, snail mail, there are so many opportunities for miscommunication or a lack of communication. And so again, with providers coming in and out of network and seeing, you know, different levels of patients based on their contractual agreement with the health plan, and depending on that line of business, you know, having that level of information accurate at the right time is critical. And, you know, we have all agreed that, you know, technology is going to help and aid in that process. But owning the data, owning the way we communicate the data, and we've seen it in people, you know, reaching out to us via the chat feature, and again, can't keep up with it because there's so many great questions and sharing quite a bit of information. We really are better together. And so I'm going to turn to Rob and Alex to see if there's any additional closing statements that you would like to make around no surprises and really understanding there are going to be continual changes.
Yeah, thanks, Michelle. And you know what strikes me, there's a few thoughts. One is the API vision and the rule, very exciting. But I think the masses that we're hearing is if the information on the front end that is supplied through the API is inaccurate, then we really haven't solved the problem. And what I really liked when Josh said that there needs to be a PSA, a public service announcement to consumers about these new rights, I would also suggest we need a similar type of outreach, in particular to providers, to let them know about not just the changes in the law, but the importance of accurate directory information. I think in my previous life, I worked for a provider association, and there was always a lot of finger pointing that, oh, it's so complicated and it's so difficult because we have contracts with so many health plans. So I think the provision in the No Surprises Act that requires the provider to come up with processes to find solutions to this problem, I think is important. And where we can play a role in both the provider and the payer space is by helping to identify best practices and use cases where a provider has solved the problem, where a plan has solved the problem. And so I think a lot of outreach, a lot of communication, I've heard that theme a lot today, that plans can reach out to their providers and say, hey, this is important. Let's work together to solve this. I won't put Soren on the spot, but there's a lot of talk about a single source of truth. And when I think of directories, I think there's a lot of similarities to what the industry went through on credentialing, where it's difficult when the provider's forced to go to multiple different places with essentially the same information. So I think the more we can automate, as Land said, the more we can consolidate, and the more that we can prioritize the accuracy of provider data, I think will be that much further ahead.
And I don't feel on the spot. I completely agree with what you said. So, but it is going to be challenging. And Linda, I think, raised an important point: timeframes. How quickly can you do some of this stuff? And there are countervailing winds, if you will, because more data is being required now that is directory based, and data that's even harder, I think, in some ways to obtain and verify for its accuracy, cultural competency, things like that, which are important and we need to solve for. But how do you standardize cultural competency? Or are we all going to just make it up as we go along? And that is a concern. And it'll take I don't want to say forever, because we don't have that. But we need to also possibly chunk some of this stuff up to, what is the immediate problem? What affects the consumer the most? And then layer on top of that through standards, what else do we need to provide and how do we provide it in terms of information? To me, the ultimate goal of this is the patient needs accurate, timely information.
So and I'm going to jump in and just to make sure that it's super clear. Like, I don't believe that APIs alone are going to solve any of this. It's if it's an API, it's garbage in, garbage out. If we have garbage data coming from the source, that's what you're going to get on the receiving end. But I think that what's important now is that these APIs can allow, first of all, standardize the data so that it can be used for different types of data analytics and can be pulled together in a more automated way that will allow us to do, I think, additional analysis to identify where inaccuracies exist or potentially streamline the process of correcting those inaccuracies. There's, I think, a lot to be said for providers being able to, potentially update their information in one place and have that disseminated to the other, or providers updating, I think I said payers, providers updating their data in one place and having it disseminated to all the payers that they work with. If that's a possibility, the chances of increasing our data accuracy go up because the burden to do so, to keep your data accurate, goes down. I think there's a lot that we can look at in that space, but it's going to require And this is why I say it takes a lot of work. It's going to require other different policies, additional technological development, and buy-in from industry that everyone has to say, yes, this is a problem that we want to solve. This is somewhere that we're going to put resources, do additional development, and work with all stakeholders to get towards that more accurate data. So, but that's why I said, it's a long way to go, but I think we're on the right path. I mean, we have more resources than we certainly did before. And we're aligning in direction in some cases, with the standardized data. So those are all positive things. We gotta look at the wins too. So those are wins.
And Michelle, if I can, let me throw out a word that I think is applicable here. And folks may laugh. That word is easy. I think on both sides, in particular, Josh, you tell me. Patients want easy access to this information, and times have changed. We're no longer picking up the phone. Now we want an app. We want that information on our smartphones. It's got to be easy. And for providers, they've got a lot of things to worry about, not least of all providing patient care. What we have to do, to Linda's point, is come up with a process using automation that removes the burden from the process, so there's no barrier for the provider to get that information. I've never met a provider who said, I don't want to give accurate information to my health plans. Never. So that's not the issue. The issue is, how can we streamline and automate that data flow? And I think that's maybe where WEDI can step in and help.
That's great, Rob. And Alex, thanks as well, because, you don't want necessarily inaccurate data in and then transacting that level of information. But Rob, to your point, the industry is asking, how can technology determine which is the right provider for me as a consumer, as a beneficiary, et cetera. So technology is something that's being asked, and even providers, as we all know, some of our providers are so technology enabled that they're able to do everything with you as a patient on an iPad or an iPhone or a Droid, any other type of device that they're able to do the things that they need to do, check your x-rays, even though, the provider ordered your x-rays yesterday, it's available today as you go in as a patient. So technology is a part of our DNA, and it's going to always be a part of our DNA around provider information and ensuring that we are able to transact that level of information. Again, quality of data. Technology is a part of the process to help resolve inaccuracies or aberrancies, if you will. But our providers, our technologists, our developers, they're all human. And, I look at it as, we all talk about artificial intelligence back in the 80s, the 70s, and artificial intelligence continues to be a part of our whole healthcare marketplace, anything and everything that we do. So again, I think this has been a wonderful discussion today. I've got 6 follow-up items, potentially for additional panel discussions. I know this panel itself will be back again, so that we can continue this series. Please, any questions that this particular audience may have of us, we ask that you please reach out to us. Again, just because you leave the session today doesn't mean that something's going to not pop in your head tomorrow and you have a question. We're always here. Highly recommend, if you aren't a member of WEDI, please feel free to reach out to Bill. Reach out to any one of us. We would be more than glad to direct you to Bill, and we'll help you with that membership opportunity. But with your membership, we would appreciate your participation in the Provider Information Work Group. Again, we meet every second Wednesday from 3 to 4 Eastern, and we look forward to our next steps I know we've got quite a bit of questions that are coming in, and I apologize. They're just coming in very quickly. Want to say thank you, because without your questions and some people answering those questions also, we appreciate everything that you're doing. I'm going to turn it over to Michael. Thank you. Have a wonderful afternoon. Michael?
Thank you so much, Michelle. And thank you to all our panelists today, Linda Rowe, Alex Muggy, Josh Roll, Tammy Weaver, Soren Davis, and Rob Tennant, along with Michelle. Thank you for attending, everyone. For those who are still on, if you still want additional education on WEDI, especially about the No Surprises Act, not only the Provider Information Work Group, but May 11th, our WEDI Work Group Open House, free to the industry and virtual. May 23rd to the 26th, our WEDI Spring Conference, virtual. We will have No Surprises Act content there. And August 2nd and 3rd, WEDI Summer Forum, our first in-person event in quite some time in Chicago, Illinois. We just finished the initial preparation, the content for it, and the No Surprises Act will have a prominent role on day 1, August 2nd, of our summer forum in Chicago, Illinois. Learn more and register for all these at wedi.org. Enjoy the rest of the week. Have a great time.